Hi guys, thanks for coming here on such a short notice. And the very idea is, I'm at the ANSIPS conference. You know what I do at Dr. UK, and there would be like around 2,000 psychiatrists who attend the event, and we have a stand there, and we are one of the sponsors at the event. I did not get a speaking opportunity. The intention is like to tell the psychiatrists, whoever aspire to come to UK, about the journey. And you two are the ones who I've known long enough, known personally, and heavily respect as well. Raja has been here in the system for as long as I've been. I've seen him, the amount of the work he has done. I can see the smile on Manan's face. So I'm sure that you had followed him before you made your move as well, Manan. And I had a number of doctors telling me how they have benefited just following Raja's advice or watching his videos. And I know that he does it like within such a clear, open mind and a heart as well. Manan, you've done remarkably well. I've followed you as well, and then your podcast in on psychiatry or the way you progressed in the system, which in itself is a bit complex, at least from my perspective, and the doctors I engage with, you navigated through well. So I set up some series of questions. This is more like, say, if we had an speaking, 30-minute speaking event at the conference, but I would imagine that this could translate and help doctors anywhere in the world as well. What are the questions those doctors would ask? So I put like around 6 to 7 questions, but I want you to openly challenge or ask or suggest something else as well, whichever you think is relevant. I'm hoping to finish between 30 to 45 minutes, but let's see. You okay with that?
Yeah.
Okay, brilliant. So I want to keep this candid. I want us to, one of the big reasons to start it as well, because that we could be candid. I know you and I like both of you personally because you do it with a plain open heart. And any advice, it's not indicated to encourage recruitment or Dr. UK, not at all. Idea is like from your experiences, share and discuss and tell what you would say if it's your brother, if your cousin, your friend's son, or anyone is coming or planning to come, what you would advise. I want you to give with kind of that kind of an impression. Any points to before I go and then put out some questions? There are only like 5 or 6 of them.
No, that's fine.
Yeah, I think we'll try and inculcate everything in the questions, and then we can also have a freewheeling conversation.
Perfect. Begin with Raja. You've been here for 20 years. I've been here for 20 years now. We've been like the oldies, and we don't look that bad. Uh, and how's your experience? And Manan, you've been here like 4 years now, right? Or 3.5. So, how's your experience been? Is it worth leaving home, family, friends, and maybe there are some doctors who have done exceptionally well. I see some of my friends from the medical school who have done exceptionally well, a lot better than the ones in the US or over here as well. Do you see, is it worth now in the new world, like 20 years down the line, would you tell yourself, Raja, hey, you've done the right thing? Or uh, what's
Yeah, I
your
think I would say that, whenever we talk about UK, coming to UK, so one of the things I don't like is that I start from bashing Pakistan or India and say that, things are not good there, so that's why you come here. I think this is not the right approach. Things are good there as well. There are very good training programs there. They are making very good doctors as well. But talking from a personal reasons, the reason I came to UK, when I was a medical student, I was looking at psychiatry as a specialty. And at that point in time, I thought, the training opportunities in UK were offering me more than what I was getting in Pakistan. So, the training I thought was more structured in UK, and I thought, uh, the kind of experience, exposure I'll be getting from UK, that would be good as well. So that was why one of my reasons, I wanted to come to UK and experience it and see how it was. So I first came in with an open mind. How I'll go and try, and then if it doesn't work out, then I can always go back to my home country as well. So I think it's not just about that you are trying to go after a specialty or training. It's also about experiencing the world. See, when I was living in Pakistan, I'm from a very small city, and every time I've gone from a small city to a larger city, I had this feeling that I'm experiencing something new in terms of the culture, in terms of experiences, in terms of relationship, in terms of social context. So that was one of the other factors that, coming from Pakistan to UK to actually actually become part of an international workforce, make friends from all around the world, and working in different culture and understanding them as well. So that was one of the other things. And I think that third thing I would say that it's never easy, to be honest with you, for any immigrant to actually leave their home base and their social circle and then go, especially your parents. Because this is one of the things, people ask me, what are the things you actually miss? You actually miss the fact that you move away from your parents and your parents are getting old. Your brothers, sisters, if you're close to them, you're moving away from them. So you're actually leaving a very secure base, family base. Friends, you can make new ones as well. Sometimes your friends also follow you, from the medical school and come abroad. But family is something you actually miss when you come to UK. So I think the reasons could be very very broad. I don't think there's one reason or or just a single reason that people should follow.
No, Manan, what's your thought? I love the idea, by the way, open mind. I kind of say this. Don't
Yeah.
come with set expectations.
Mm.
Because I think my psychiatry friends in the US, they earn like around 400K. Over here, obviously, we don't get something like that. And I would say that they're very happy, but I think everyone have their own version of seeing things. But then I do tell the doctors who ask me, is it worth coming? Come with an open mind if you want to come. But what's your version? What's your story?
To start off, thank you for the kind words during the introduction, and it's always fun. We did this once before as a live session, and it was really fun to hang out with both of you and
Mm.
talk about life and reflect on life, especially as international medical graduates. So thank you for doing that. Thank you for inviting me. To start off, I'd second a little bit of both of what both of you said. One thing that I think all of us have been through that transition when we compare. Let's start off with that monetary discussion to pick up from exactly where you left off, Naveen, is that you realize that money is a means to an end, and there's a certain amount of purchasability to how much amount of money you make. That is what is going to decide how rich you are or how much money you're saving. Because at the end of the day, even within the UK, the cost of living is massively, massively different. I started off my career in Northeast Lincolnshire. The cost of living was less than half of what I on an average spend in a month in London. And I'm sure it's different in different corners of the country. So as far as monetary thing is concerned, please do bear in mind that the conversations, money at the end of the day is a means to an end. It's not the end. So as long as you're getting your needs met, as long as you're living in a reasonably good home, getting all the desires fulfilled, and you can afford the holidays that you want to afford, the remaining amount of money, I'm not sure how much it matters to 70-80% of us who just wanted a good, simple, normal life. So that would be point number one. Point number two, of course, yes, absolutely, from what Raja said. Um, one country doesn't need to be bad for another one to be good. Two countries can be good. And you want to come from that point of spirit where you want to have a certain sense of loyalty to the country that has brought you up, but at the same time have a certain sense of dedication to the country that is essentially the country that you're living in and you're working in as well. And you don't need to choose one. Your home country doesn't need to suddenly become bad for you to love the country that you're living and working in as well. So having thought of all of those points, my mindset when I moved was pretty much like that I want to learn more about mental health, especially the field of psychiatry is so fascinating. And I say this with no hatred towards any other fields in medicine, but a hernia is a hernia in any corner of the world. Schizophrenia, the content of the delusions, the hallucinations, the manifestation of depression is so beautifully different in every corner of the world. And as a student of mental health and psychiatry, we should be equipped to be able to deal with and have reference points with people who have grown up. Like I tend to say this, I grew up in Jamnagar, which now has become famous because of the Ambani wedding and everything. Did my psychiatry in Ahmedabad, which is a city. I lived in a small beach town in Northeast Lincolnshire, where I saw a lot of people who are from a very different and diverse background from what I see now in London. And that has helped me learn a lot about people, learn a lot about mental health, learn a lot about how these symptoms manifest in different people. And I think coming from that mindset is really helpful to get to see and keep an open mind about where we want to go in the future.
One thing, I'm so pleased actually I mean, obviously you're making me passionate. Psychiatry is not my background as such. You're making me very interested and then passionate about it. Other point, I would say, I think embracing the change is crucial. I see probably over the years there are people who bash England or India or back there, Pakistan, the home countries as well. But at the same time, it took me almost 7 to 8 years to have the Christmas tree. It's not that you are becoming Christian, but it's embracing the culture. It's more for the fun. It's more into the new country. And I think that is quite important to like the place. And then that's when, once you like a workplace, once you like the country, once you start to engage with the people, you become part of it. Is that something that you reflect? Because now, now maybe a bit less, at least from my personal interactions. But there are quite a few doctors I came across who are very unhappy, disenchanted because they had different set of expectations. They kind of stay in their own kind of silos. What your version? Is it like embracing crucial or is there anything more than that?
Raja, do you want to go first?
I would say, you see, if you UK is a very multicultural country. It's more multicultural than what we think when we are not here. So if somebody wants to come here and they say that, I want to find mini Pakistan within UK, so they will be able to find that. They will be able to find that social circle. They will be able to find the food if they look more closely. They will be able to find those shops. They will be able to find all those things which they get back home, because it's a very multicultural. But I was, again, as you said, if you are living in, I always encourage people to actually explore a bit more. You see, explore other cultures, other South Asian cultures, make friends with Indians, Bangladeshis, Sri Lankans, then, Arabs, Nigerians. If you find a lot of doctors, a lot of different type of doctors who are living in UK, but also understanding the local culture. When you are working, you obviously, when you come to UK, you're working in NHS. So becoming part of the team, attending the team meetings, attending the team days out, all those special festivals, all those special times that you you get to hang out with them. All of that is very important, especially when you have your children in this country. They will they will have experience of living with two different types of things. They will also have your home culture there at home, and then they will be going out, and then living with the English culture. So we need to have very open mind about that. We need to adopt that. We need to understand our background. We need to be proud of our background. We need to be sharing our culture and history and everything, but also have that respect that we are living in this country. Is something where this country is giving us a space, and giving us the chance to live here, to also to understand the values and enjoy them as well.
Maya, what's your take? You've been here much lesser than us.
Yeah. I've been here for a little less than both you guys have, but also I think something to really compliment is a lot of NHS trusts have a lot of these well-being events and mixer events where people celebrate their own culture, bring their own food, celebrate festivals, and kudos to them for creating that safe atmosphere where people get to learn about each other's cultures as well. Because we don't realize when we come from a different country that everyone surrounding us on that table everyone was belonging to the same culture. Whereas now when we step out into a different country, we're not only meeting people from that country, we're also meeting people from other countries, which are very different to us. And hence being able to have that space where we understand all of those things and try and ace, because at the end of the day, you want your workplace to be a happy place. That's how you do good work and others get motivated to do good work. If at the end of the day, if we're doctors, we're usually going to be chairing some meetings. We're going to be sitting in a position of responsibility, and we're going to be supervising people. You might start your career off as a middle grade, as a junior grade, but eventually you end up being in leadership positions. And hence, it's not only is it your job to make your service users or your patients feel comfortable, but also to make your team members feel very comfortable and feel that you're participating in their celebration of their culture, which I think is the most beautiful part of my job, because I get to learn so much about so many different cultures, celebrate and have that sort of broad vision where you get to learn about mythology, you get to learn about religion, you get to learn about celebrations, you get to bond over Asian parenting with your friends from Bangladesh and Pakistan and Sri Lanka. So there's a bit of laugh and fun, and I think that's a good part of the job. that you get to see and learn and broaden your horizons. And I think the kids benefit from the fact that they grow up in a multicultural society as well. People talk about the cons of all of that, but people, I think, don't really talk about the pros of all of that and how that broadens the vision of someone who might grow up thinking or having some stereotypical patterns sometimes. It's important to do that. Even if you choose to stay in your same country, even if you choose to stay in India and Pakistan, and if you feel that the UK is not the right place for you, at least do something to broaden your horizons. Get to learn about other cultures, get to participate in a work setting where you're dealing with people from different cultures. That's really important, I think. As a psychiatrist, again, not to sort of attract you more towards psychiatry, Naveen, but yeah, in psychiatry, very important, I think.
This is really nice. I'm going to move things a little bit quicker. I'm going to keep it crisp in terms of my questions because, as I said, this is more like the attendees asking the questions. One of the things I see that a challenge what a lot of new doctors face is about the differences in the practice in Pakistan, India, or in the subcontinent, or in other countries, Nigeria, Egypt as well. And when they particularly in reference to psychiatry, if I'm not wrong, it is predominantly medication driven and it is predominantly therapy driven here in the NHS or in the UK. What's your version of it? Is it true or and do they have to make any sea changes in the way they look at things?
So if you want me to take this one first, I think mental health is a field which is rapidly evolving. We don't know half the amount of stuff about the brain as we do about the heart and the liver. So we need to come from that place of humility where the brain is something, brain is a part of our body whose understanding is rapidly and constantly evolving. And hence we're just trying to figure things out. It's important to come from that place of humility and awareness. The good thing about psychiatry is that there's a very small bunch of medications. As far as if we're looking at the thing that we need to memorize during our student phase, someone who's done psychiatry in India, Pakistan, Nigeria, the US, New Zealand, Australia, although very different training programs, they would still be able to at least survive in a different country for their basic 9 to 5 job because we still use the same medications every corner of the world. And an analogy to that I think might be interesting is internal medicine is vastly different in a country like India and Pakistan than it is in the UK, because internal medicine in India and Pakistan is a lot about communicable diseases, whereas in the UK is much more about non-communicable diseases.
Okay.
Whereas it's schizophrenia treatment is still the medications you prescribe for schizophrenia in India and Pakistan, very similar to the medications you prescribed in the UK. So you don't need to learn more things from a pharmacokinetics or pharmacodynamic perspective. The things that you probably need to learn and understand more is the Mental Health Act side of things, the way the law works, which again, in India, I'm aware that the new Mental Health Care Act is very similar to the Mental Health Act in the UK. So these are things which, yes, there are differences, but the differences, to be optimistic, are in the systems, not in the core basic base of your subject. So if the base of your subject is clear in psychiatry, if you know your fish psychopathology well, if you know your basics well, if you know your delusions, hallucinations well, you know your benzodiazepines well, your antidepressants, antipsychotics well, then you're going to live here. It's not going to be very difficult.
Yeah, I mean, I would say I second that, but I will just say, practically speaking, when people first come, it is an expected thing that initial few months you will struggle to not struggle, but you may find it a little bit overwhelming that to try and understand the system. So, and by understanding the system, there are a lot of things which you may have not seen. The way services are set up, like what is the community mental health team, what is the crisis team, what is the assertive outreach team. So these are the community team which you would get to know what they're doing. The role of a community psychiatric nurse, how highly trained our nurses are in UK, the role of occupational therapists, the role of psychotherapists, and how do they fit in the team, and what is your role within that. Then there's like aspect of an inpatient service as well, that what actually happened in inpatient. Sometimes we have separate, quite a lot of time in UK, we have separate inpatient and outpatient teams. The inpatient is only looking after inpatient, the community team is looking after the community team, then the subspecialties within the psychiatry. So it's not that you haven't experienced that. You wouldn't struggle to see the patients. You will find the symptoms. You will be able to recognize the symptoms without any problem. But this is just understanding the system, how things are happening, where are the patients coming from, what is the role of primary care in all of this, how much a GP can treat, when the patient will come to you, what is your responsibility, how do you follow them up, risk assessments, all of those things, and the Mental Health Act. Obviously, we have the same thing. The Mental Health Act. I've seen the Mental Health Act in Pakistan, which is kind of almost like similar to the UK Mental Health Act, but they never actually practically apply. Here, those act would be practically applicable. So if you're working, especially in the inpatient service, what are the restrictions that the act has got and all that. So these things are not difficult to learn. This is something because you haven't experienced in the past. This will be something new for you to learn. But then slowly and gradually you will start to learn that. And as you know, we've already said that the medications are actually the same. This group of medications especially are the same. Just about the protocols of how when you start them, how do you do that? What is the monitoring requirements and follow-up requirements and all of those things. These are things you can pick up very quickly. And I've seen and I've sort of mentored quite a lot of Indian, Pakistani, Nigerian, Egyptian doctors, and I believe they are very good. If they have done the MD or FCPS back home, they're actually very, very good doctors. When they come here, they don't actually, within a few months, they are actually up to speed, and they understand system very well. So it's not that this is a massive struggle. I would say.
Just following it up, this is really informative, particularly the points you mentioned, Raja. So I hear, and Manan, you probably can relate to it as well because you've done your post-graduation. And an average doctor sees in 5 to 10 minutes a patient in India and then prescribes a medication and discharges them. That happens in medicine or in probably in orthopedics as well. And so in psychiatry too. But over here, an average consultation is like half an hour to 1 hour. So how does the transition? How can they understand? Because they probably come with the mindset that, okay, I've diagnosed in the first 5 minutes, and then this is the medication I should be prescribing them. So how do they transition to this? And is it the monitoring, which is a crucial one that they need to learn, and MHA? You're on mute, Manan.
Sorry. I think there's a mix of everything. So if we're looking at the MRC psych exams, when you'll sit for your CASC exams, which is a part 3, you don't have a lot of time for a whole scenario. And the main reason why the system designs stations to be 7 minutes or 8 minutes, even when you're giving the PLAB, the stations, if I'm not wrong, are 5 or 6 minutes, is because the system wants you to be able to see patients rapidly, make a diagnostic assessment, because that will also happen. A lot of times people, when they move countries, they think that, oh, here in the UK, I will have at least 45 minutes to 1 hour for a patient. You wouldn't always. There will be times when you will be, say, in a liaison placement or even in a community placement when you've got 2 people waiting. You're in an inpatient setting where you've got to deal with 5 different things. You might not always have that structured 45 minutes for the clinical consultation. Also, the main change also is another change that you want to get used to is the documentation side of things. Producing a comprehensive clinic letter or making ward round summaries, all of those things are very important as well. I think there's a bit of both. There are consultations I'm aware of in India which also go on for half an hour, 45 minutes. Initial history taking, of course, in my department where I did my training, our initial history taking sessions used to last 2 hours, 3 hours. Of course, in an outpatient setting, things are different. But the quality of records that you produce in an inpatient psychiatry setting in India is almost at par as what an inpatient clerking here is if you're in a good teaching hospital. So these are things, the systems, like Raja said, are slightly different. The times that you'll get depend on how busy the team is, what's going on that day. You might sometimes have the full allocated time, you might also not. So it's important to be open about that.
So I say the important points, system learning is crucial and documentation is quite important. And that is where probably one of the areas where you will utilize your time, and then they need to learn to be efficient, because I've recognized some doctors actually with 30-45 minutes, new doctors who have recruited kind of struggle sometimes because they think that it is less time. While they were happy with 5 minutes with the patient in India, with 45 minutes, they couldn't even accommodate and work in there. I guess it's predominantly because we follow a structured pattern, or maybe a defensive medicine as well. I mean, at least from any perspective, I can say that. But this is the right way. I'll move out from here. Next, I'll go into the career progression side of things, common questions. Uh, both of you have done two different versions. You're the CSR master and you're the CCT head. And tell me, so there is this doctor who I recruited 1.5 years ago, and she is at that junction now. She intends to continue with CSR, stay in the non-training job. I said, like, think about CCT or SC4 applications. She's post-MRC Psych. What's your recommendation, Manan? And Raja, you share your version as well.
Um, it depends on your choice as far as what you want out of your job and your personal life. For me, I had MRC Psych before I moved. So I had a choice before I moved countries whether I want to enter into a training pathway or I want to do CSR. The thing that attracted me, and it's funny you mentioned initially that you're going to ANSIPS, because I was recruited like that. Navigo came to ANSIPS and I was presenting a paper at ANSIPS where Navigo sort of offered me a job, and we had a conversation, but I was only first year in my MD training. And I said, it's 2 more years, and you're not even a teaching hospital. So if I'm taking up a job with you guys, then I'll need to do CSR. And they're like, yeah, whatever you need. And the fact that they were this supportive was what was the main thing that led to me making the choice to actually go for CSR, even though I had the option of entering into the training pathway. And I don't regret it for a second, because the fact that when I moved countries, I got into a job where the trust that I worked with was fantastic. The team was fantastic. I still am in really, really good terms with the medical director there, Dr. Ahmed Sajjad. I think Raja might know him. He's the treasurer for BPPA. Um, so it depends on what you want, how happy you are with the job where you're at. Do you want to move places? CCT is also, to all my friends who've done training, they've really enjoyed their training years. They've really enjoyed the special interest niche that a CCT structured program provides. There's, of course, a lot of paperwork with the portfolio pathway, which was previously known as CESR. But there's the luxury of being stationed in your job and then taking it at your own time, your own pace, and having that choice to sort of choose as to what and how do I want to go through the pathway to becoming a consultant, whereas the CCT is a bit more structured, which is really helpful for a lot of people. I don't know what points Raja wants to add, and then we can have a further discussion around it.
So I would just say that first thing for international graduates to understand that the psychiatry training in UK is generally broken up into two different parts. So this is something a lot of people get confused about. Like, for example, if you're coming from Pakistan, they're training 4 or 5 years, directly in FCPS training. And after that, during that, you pass FCPS. And as soon as you pass your exam in the final years of your training, you finish your training and you become a consultant. So they sometimes find it difficult to navigate that, why, if you pass MRC Psych, why you're not a consultant, what happens. So basically, psychiatry training is broken up into two different parts. There is what we call the core training, which is for 3 years, and then ST training, which is at least for 3 years. You can have more years added if you want dual CCT and stuff like that after that. But what we do, MRC Psych is actually not an exit exam. This is something which we do after the first, during the first 3 years of training, during the core training. So what an international doctor can do, if you're coming from India or Pakistan, if you've done MD or FCPS, and if they've done MRC Psych, so basically they can consider themselves equivalent to a core trainee. At least, they are. I think their knowledge and confidence is above that. But at least they can bypass that stage if they pass MRC Psych, so they don't have to do the basic training in psychiatry. And then the question of that you go for ST training or not. So then ST training 3 years for single CCT, which is old age, general adult, or CAMS, LD, forensics, and or medical psychotherapy. Sometimes we have dual programs when you can actually do dual training as well. So I think it's kind of a personal choice if you want to go for training or non-training. People sometimes find in training you have rotation. So for example, if you're doing ST training for 3 years, 3-4 years, you won't be in one place. They will expect you to be rotated between hospital, between different. Even if you are old age psychiatry training, for example, 1 year in one place under one consultant, another year in another place with another consultant. This is not just that you are rotating within the hospital. Sometimes they are within the trust, sometimes within the deanery, sometimes you are actually an hour away from the first placement. So in the training years, they want you to give you that experience, that you experience different teams and understand different setups. So this is something people sometimes find annoying, that I have to move around and I can't stay in one place. If I'm renting a house or bought a house in one place, I have to go to another place. My kids have to move as well and all that. So if you are doing Caesar or portfolio pathway, then you can have one job, and you might be just focused on that. But then the responsibility of gathering all the evidence would be on you. Where the on training is, a lot is actually structured around you. So all you need to do is do your workplace-based assessments, enjoy your time. You have a special interest day, at least one day a week, where you can do whatever you like. You can spend that on research. You can spend that in doing exploring other interests you have. So it's sort of I don't go into this debate about which is superior, CCT or CSR. I would say it's kind of both are fine, and it's sort of a personal choice. At the end of the day, practically speaking, when you see a consultant in UK, you won't be able to tell if this person came through CSR or CCT, because their confidence level, the way they manage things and all that would be same. It's just the personal choice of which pathway you want to take, and how much time you want to how much time you want to spend, your priorities and all that.
Yeah. So that's right. You want to add finally anything on this, or Manan?
No, I think I agree. Yeah, it's about that, making that choice as to it would really help. Just to add that pointer, that of course, if this is specifically for people in ANSIPS, then most people would be on the training pathway in psychiatry. But if for the wider audience, for people who've never sort of thought about psychiatry as a career, and those who are looking into delving into that, for you to be able to apply in portfolio pathway, you need to have some sort of training, even if it's international. So if you're, say, moving from India or Pakistan or another country, if you want to go through the portfolio pathway, you need to have some sort of training in psychiatry and need to be able to evidence that, because that will form an integral part of your portfolio and submission. So if you want to start your career off after undergraduate in the UK and want to become a psychiatrist, then I think CCT might be easier and more structured, because then 6 years, bam, you're a consultant. Whereas if you've already done, say, MD, FCPS, or some other undergraduate psychiatry or postgraduate psychiatry course in your home country, then you probably might want to look at a bit of both and then make that choice.
Quick question. So if you're doing FCPS in your third year or in your MD third year in India, so what are the competencies you think that they could bring along which could help you with your CSR applications?
A lot of teaching hospitals in India and Pakistan that I know of, because I used to be an active participant in recruitment campaigns for my trust when I was in my previous job. We liaised with a lot of teaching hospitals in India, and they are actually creating their structure around their monthly and bi-monthly and yearly supervisions to sort of help formulate a portfolio for CSR. So in training in the UK, you've got ARCPs, right? At the end of every year, which is, if you're a non-trainee, you have an appraisal at the end of the year. And if you're doing a middle grade job, what you're doing is you're trying to make the appraisal as close to an ARCP as possible. All of that is secondary evidence according to the portfolio pathway, but important evidence nevertheless. So if you're going from India in your, say, first, second, third year of CPS, FCPS, or MD psychiatry or DMB psychiatry, really, really good and helpful thing would be to go through the curriculum, the general psychiatry core training and higher training curriculum on the GMC and the Royal College website, and try to see what all things are there which you can evidence, like case histories, minutes of meetings, complex case discussions, teaching evidence, leadership evidence, management evidence. Coroner's reports are still coroner's reports every corner of the world. All of those things are very important evidence. Psychotherapy is still psychotherapy. CBT, DBT cases, you do it under the supervision of your home team. All of those are important evidences that you can start amalgamating while you're still working there.
Brilliant. Brilliant. I think this is really so relevant. Last two questions. I'm going to come. Section 12 ACRC status, because not many, I would imagine, that when you come over here or before you come, you do not know, but then they're quite important for your career progression and even upscaling your salary and be able to do locums and then make other commitments. Can you briefly break down your understanding of Section 12 and in what order, and how much time would it take for a new doctor who has completed, let's say, a Master Psych, at least Part B, not the cask exam.
Raja, do you want to take this
So,
one first? Then I'll come back.
yeah, I mean, this is it would be difficult to explain to people who don't know about much about the mental health. Like basically, the section, there are basically two different things: Section 12 approval, and then you have the AC or RC approval, which is a higher degree of approval. So consultant level people will have a RC or AC approval, which means that they can become responsible clinician for the patients who are sectioned, who are under their care, either inpatient or they are on the community treatment orders in the community. Section 12 is basically made up for doctors who have at least 3 years experience in psychiatry. So Section 12 is like kind of middle grade doctor can become a Section 12 approved doctor. Our SPRs, our ST trainees are usually Section 12 approved, especially doctor graded also can get Section 12 approved. And sometimes you have doctors who are not even psychiatrists, they can be Section 12 approved. Like for this example, if somebody is a GP, they can also become Section 12 approved as well. Section 12 approval is basically that, when you're doing a mental health act assessment, especially in the community, you need two doctors to do the mental health assessment. And ideally, they expect those two doctors to have the Section 12 approval, basically, which in very simple terms mean that you have the understanding of the mental health act, you have experience of psychiatry, and then you have attended the courses for Section 12, which means to gather information around the mental health act and how it works, and what are the rights of the patient, what are the things you should be looking for when you're sectioning a patient. When we use the term sectioning a patient, it basically means that when you're treating patient, admitting patient against their will to a hospital in very very simple terms. So when you first came to UK, you will obviously not have that. It's something that you will have to work towards. And I mean, I've seen people who have come from India or even Pakistan as well, who've come after passing their MRC psych exam, and then when they were in UK, within the first 6 months or 12 months, they were able to gain those competencies to actually apply for the Section 12 approval, and then gain that. For AC and RC approval, do you need more years of experience? That is something that will come with time, and then when you become a more senior doctor.
Yeah, I think just to sort of add my 2 bits to it, in very, very simple terms, like Raja said, if you want to admit someone against their will, then you need to be Section 12 approved. Section 12 is a section of the Mental Health Act, which essentially, so if you want to admit someone against their will or their consent, then you need to be a Section 12 approved doctor. Now, once they're admitted, if you want to take the responsibility of that patient, to say send them on leave, discharge them on a community treatment order, decide what happens with them, you need to be the responsible clinician. So these are the two terms that we want people to be orientated to: Section 12 and responsible clinician. To become a Section 12 doctor, if you've got MRC Psych, is much more simpler, because with 3 months and your trust supporting you, if you've got MRC Psych, you can become Section 12. Whereas if you don't have MRC Psych, say you've come through the International Medical Graduate route or the PLAB route, from what I know, because one of the people that I'm supervising right now is on that pathway, is you need at least 4 years of psychiatry experience to be able to apply for Section 12 approval. So essentially what Raja said, that you need 3 years or 4 years of psychiatry experience to be able to apply for Section 12. Because if you've got MRC Psych, you would have been in psychiatry for at least 3 years by that point. Then to become an AC, if you've got MRC Psych and you're on the training pathway, then by the time you finish your CCT, you will be on the specialist register, which gives you a direct entry to becoming an AC. Whereas if you're on the other pathway, say you're planning to do CESR or doing CESR, you've got MRC Psych, then you need at least, according to most places, you need at least 7 years of experience in psychiatry to be able to apply for an RC AC status. So once you become an RC AC, then a lot of trusts start opening up doors for you to become an ACT-UP consultant or a locum consultant, which is like, in simple terms, in the terms that is used in India, is ad hoc consultant. So it's not a permanent consultant or a substantive consultant according to the UK appointment, but an ad hoc or a locum appointment. So the understanding is that within those 12 months of them offering you the locum role, you will then complete the remaining formalities to be on the specialist register. So there are these 3 things: Section 12, which is the first step; AC, which is the second step; And then, of course, being on the specialist register is what leads you to become a substantive consultant. That's where you want to be at the end of the day. Be it through the CCT pathway, all of that is much more structured. If you go through the CESR pathway, all of those things are things that you'll need to navigate a little bit by yourself, albeit if you've got MRC Psych, then Section 12 is slightly easier.
So broadly speaking, Section 12 will allow you to be an on-call registrar and be able to do locums and take responsibility at the registrar grade, while Section 12 plus ACRC will allow you to act at a consultant grade. Am I right with that?
There's exceptions to all of this.
Yeah.
Everywhere. There's people who are substantive consultants who are not on the specialist register that I'm sure Raja knows, I know. So there are some exceptions to all of those things, but broadly, yes.
So you can still become a consultant, but not being an RC. These are a little complicated to understand, but what we explain is a simpler version of that. There are exceptions to all of these things.
Okay, let's not go into the
Yeah.
exception. My last question, and then Raja, I want to ask you, speak a little bit about the PLAB, because I hope that there might be some PLAB doctors listening as well. But before I move to the PLAB version, so city versus towns, because both of you have started in the cities and migrated to the towns or moved from the town into the city. What's your version? Or is it like, which one you'd prefer? Because people do ask, I mean, where should I start? I think everyone have their own perspective. I kind of let them make their own decisions. But what are your thoughts?
So I would say, one of the things which, I mean, at least doctors I know coming from Pakistan, they have this bias that all the good training, all the good things are actually happening in big university hospitals and the big cities, because this is what happens in Pakistan. And if you need good training, you need to end up in a big city, in a big university hospital. Otherwise, the periphery and the villages and all that, you might not get that level of exposure. But what the first thing is to understand that, is UK's rural areas or the rural settings are actually not that bad. They are fairly good in terms of the facilities. They are also sometimes very good in terms of their training opportunities, their hospital, the environment of the hospital. I have worked in big university hospitals, and I've also worked in small DGHs and small psychiatric teams which are scattered in the community. And I think you get more personal care or personal relationships when you're working in a small team in a small town, because people are nicer to you. They know each other as well. There's a whole community feel there as well, and they look after each other. In a bigger hospitals, bigger university hospitals, you find that everybody is just like very busy and just on the go all the time. But then having said that, it's also true that big university hospital will have opportunities. They will have more maybe subspecialties of psychiatry. Maybe they will have more specialist interests. They will have more specialist teams than working in the community or in the rural setting. So I mean, I have worked in Wales, in different rural setting in Wales, in South Wales, many different trusts. I'm currently working in Bristol, which is a big city, relatively big city. So I would just say to people, don't be scared of the fact, that's when sometimes people get a job offer and then they put it on Google and say, oh my God, this is a very rural setting. I might not, my life would be ruined while we're working in a village. It's not the same village as one of the good things about UK is that wherever rural setting you are in, within a drive of 45 minutes or an hour, there's a big city near you. This is a very good thing about UK, I find, which is something, unfortunately, this luxury is not there if you're working in US or Canada or Australia. Their rural settings are actually far. If you're away from a big city, you are like 4 hours flight away from a big city. We are not that. We are a very small country in that sense. So, just come with open mind in that sense as well. That don't have this bias that only good things are happening in the bigger cities and the smaller cities are not worth it.
Actually, that takes me back. I did my basic surgical training, and part of it I was in clinically in South Wales, and I loved it because, as Raja said, everybody knew everyone, and then it was really good time. Manan, your version. You moved from a town into a city now to London.
Yeah, I moved from Northeast Lincolnshire, Grimsby to London, and I think it depends on where one is in their lives. Say, I know a lot of people moved with their partner and children or child. Then you've got to factor in the cost of living and the cost of everything as well. Because initially, when you're moving, it's likely that only one of the partners is earning. Of course, the other partner then gradually builds things up, and you're looking at all of those things. It's usually cheaper to live in towns than it is in cities. There's also, of course, an element of a small town, vibe and everyone knowing everyone, which is a good and warm place to start off, especially, which I reaped all the fruits of. I was very lucky in the initial couple of years of me being in the UK. The fact that, especially during CESR, the fact that everything was within a mile or two. And if I wanted to go to the liaison team, I could do that. If I wanted to go to the forensic team, I could do that, gather that evidence during my SPA time. And all of that, if in a bigger trust, I completely agree that a bigger trust would again probably have structured programs around that as well. But it's about what works for that person. If you've got a trust with whom, you've got people who say Naveen knows and Naveen has those relationships established, or if you know the CEO, or if you know the medical director, the clinical director, or a couple of the senior consultants there, that is extremely important, I think, in rather than whether you're moving to a town or city, according to me, in my personal opinion, because then you've got that mentorship there. You've got that trust there that, okay, for the first step, because there are 1,000 challenges that you're navigating in the first year and a half. And in that, if your quality of life, if you don't spend the first 6 months in London, it's fine if for your first job, because if you can save up that extra bit of money, you can have that sense of familiarity, invariably, we all make mistakes, especially in the first few years of our careers. And being in a position where you have that little bit of a wiggle room and that headspace where if you make a mistake, you know that you've got that protection and safety net around you, that is something that I value much more.
Nice. Right. Actually, these are all my important questions. But could you think of any other questions or any other points a new doctor would ask? I mean, if they ask about GMC registration, I'll make a small separate video and then run through those steps about GMC and visa. But from the psychiatry perspective, could you think of like any questions from your journey, from your experiences working with new doctors? I think these are the challenges
I think one of the things which people in psychiatry worry about is that language barrier. They say that, if you're coming to UK, will be able to speak good enough English. But I believe if you have passed the OET or IELTS according to the GMC's standard, I think then your English would be good enough. Obviously, you learn new slang. You will hear slangs. You will hear new accents. Then there's a whole aspect of understanding how things work here and all that. That is something you will get used to it. But generally speaking, the IMGs I've seen coming from India, Pakistan, Bangladesh, Egypt, Nigeria, their English is actually pretty good enough to actually practice in psychiatry, and good enough to pass the exams as well. The other thing you will find in psychiatry, the workforce is a lot more international. It's quite a lot international actually. At least the trusts and places I worked in, they were actually more IMG doctors, starting from the top, clinical director level, consultants and all that. They were actually more international doctors than the British doctors. And I think that's because a lot of the British doctors don't take up psychiatry, and a lot of these posts are actually filled by the international doctors who come and take those. So you're not in a you shouldn't really struggle with the language. This is something that is stuck in our mind, that I might not be able to cope with that. But I think you, as an international doctor, you do cope well with that.
Manan, your version or any questions from your point of view that new doctors would face or ask?
I think a couple of things, just sort of broad, two bits from my side or reflections from my side to anyone who's lived in a very different system than the UK. A couple of things is, if please don't come from a place of, oh, I need to be called sir and madam and need to get that, start off from a place of humility and people calling you by first names, but then you also calling your supervisors by your first names. That is a different culture that we want to sort of imbibe on the day we move, before we move, or at least within the first couple of months that we move. Two, it's extremely important that if you make a mistake, because the audits and the systems are so evolved, you are going to get caught if you make a mistake. So please just be honest and accept it. It's fine. It's completely fine to come from a place of honesty and make a wrong decision or do something wrong, and then accept it. It's fine. But please don't try to sort of pile on over it or go around and around. That's something that usually annoys a lot of people. And third, I think it's really important to come from that student mindset that I want to think and learn. When you're moving, don't come and put a lot of pressure on your shoulders that, oh, I'm moving for life, nothing's going to change. And this, don't overthink all of that. Just come from a point of view of getting some exposure and learning about different cultures. And then usually what happens is by 6, 8 months, people feel like, okay, I really like and enjoy working here. That mindset, I've seen people make or break within the first 6, 8 months. All the people that I've seen make a decision, positive or negative, they make it within the first 6, 8 months. And when they sort of break, it's usually because of one of these three things. Either an expectation of a lot of respect, which they might have gotten used to. Now, whether that respect's true or false, that's up for debate. That honesty and that third thing coming from a place of learning and not enjoying the process at the end of the day, because you're coming here to be happy. You're not coming here to put a lot of 10 kilos on your shoulders. So just enjoy and see where you go. Take your time.
That's really important points. And I think in terms of the goal setting and then the journey, I always advocate the journey, enjoy the journey. But when I talk about the goal, you say that there is going to be an increased opportunity for a doctor to slow down, because in multiple other specialties, in acute specialties, I've seen that doctors want to apply for training at the earliest possibility, and then they'll do everything, and then they get upset if they do not get into an ST4 position. But in psychiatry, I do not think that there is such rush, and then there is an evolving and increasing demand or need for consultant psychiatrists in the NHS as such. So that do they have to really rush for and then get into through the CSR or CCT pathways? Or again, we don't want them to slack down, but then take it in a relax. Is that how you would see?
No, I completely agree. There are a lot of people who I know, some of my closest friends have chosen to continue to be in a specialist or a associate specialty role because they don't want that added pressure or responsibility, which is completely fine. This country provides you with that wiggle room where if you decide that, what suits my life is say CCT, that's also not a bad choice. If CSR suits you, that's not a bad choice either. If staying as a specialty grade for the first 5, 7 years while you have a young kid who turns 8, 10, and then you decide to go into the training pathway, that's fine as well. Or if you decide, so there's no one correct answer. And hence you want to stay in the system for the first few months or years and then take a call on what works for you.
Can Raja, this is a very passionate question for me, and I think that you can relate because we came together by giving PLAB exam, and 2004, 5, we've seen that the MDAS and the MMC debacle, and then the bottleneck, particularly as an undergrad doctor or a PLAB doctor. Now the same cycle is repeating all over again. There's so many PLAB doctors, and I remember how devastated I felt during those periods.
Yeah.
I told the family, and then I took a loan and prepared for the exam. I moved over here, and then there are not many jobs available. Is there anything that you think would help them or advise them? I mean, from my point of view, I was advising not to give PLAB anymore, and in fact, aim and get some experience in your specialty of interest. It could be any psychiatric medicine and complete your membership. But your version, what do you think?
So
Or
it is
no?
a supply and demand issue, basically, which we have to understand that UK at the end of the day it is a smallish sort of country. Uh, and obviously when they were short of doctors, they will open the doors, they will make things easier, they will make the immigration rule easier because they want the specialists, they want that flow to come in. But then when there are too many people coming, then they have this thing about changing the rules, or too many people will be given GMC registration, but there won't be enough job. And nowadays, as you said, the people who have just done PLAB, they're applying for job, for the junior job, for a single job, you have like 200 applications. So it becomes more difficult to then get your CV noticed on those jobs. So I would say to people, I'm advising people nowadays, people who contact me and say, I've done PLAB and I've been waiting for a year, I don't know what to do and all that. So if you are in your home country, I would ask you to, not to burn all the boats there. PLAB is not at present not one of those pathways that you're doing PLAB and you leave everything else. You think, I'm not going to do any more jobs anymore. I'm just going to go, my next job will be in UK. So what you can do is in your home country, you can still pursue your training, pursue your interest, whichever specialty you're going and try and get training into that, try and get job into that, and then try to get to the next stage, which is the Royal College exams. If you're interested in medicine, MRCP, in surgery, MRCS, MRC Psych for psychiatry. It's likewise OBS-GYN, PEDS, they have their own exams. So you need to continue on that journey. That at some point you will end up in UK. That's what I can tell you. Once you have the experience, then you have the membership exams, then your CV would be looking much more impressive. So the saturation is at the junior level. At the middle grade level, obviously, it's not as saturated as the junior level. And as a consultant level, as you become senior, there are actually more jobs, because not everybody who's getting CCT in UK is actually staying in UK. They are actually exploring other countries. They're going outside. So UK is not like one of those things. You either do PLAB, and if you don't get a job, then that's the end of your journey. There are other stages you can enter as well. You can continue to gain experience, gain exams, improve CV, and then try again. So that is what I normally advise nowadays.
Manan,
Just
you're nodding. I see. Obviously, you must have come across a lot of PLAB doctors.
Of course, I heard about the whole 2008, 2009 cycle from my colleagues who are senior than me, and issues with job at that time. But I think one thing that's extremely understated is a clinical attachment. People don't realize, sometimes they feel that, oh, I did one clinical attachment, do one, do two. It's very, very likely that you'll find a job opportunity with a clinical attachment. Even if not immediately, then in the next 2, 3, 4, 5 months. But if you leave an impression there with your supervisor, with your consultant, if and when a job comes up in their team or the neighboring team, especially in psychiatry, I know this in psychiatry because within the last 4 years of me being here, I think directly or indirectly, wherever I was working, we've ended up recruiting at least 3 clinical attaches. So even if you end up being there for, say, 2 months, 1.5 months, of course, there's the whole financial commitment around it, and I completely understand and respect that you're earning in your home country, you're making money, and then you leave all of that on a tourist visa or something. You come here, spend those 2-3 months, but more often than not, that's a good investment. If you're really struggling to find the right jobs, and if you can get your foot in the door in a clinical attachment, not only will it help your CV, but it will help you network and get your foot in the door with a lot of different places. That is an important thing to sort of keep in mind if you're struggling to find leads with jobs.
That's how it worked for me as well. I think I did like around 4 months clinical attachment. 2 times you had to pay for them. And that is when the consultant said, like, Naveed, I could see you struggle. I've seen you work hard and then committed. So she opened the doors, and then that's how I got through the system. Other thing is like ALS and part of the membership exams, I think it will help, at least from my perspective. Right, guys. I think we stayed actually a little more than an hour, although I was expecting I need to do a little bit of maybe cringing and editing. But really grateful and thank you for your time.